So I'm going to pose a question, and that is, can a myelopathy or a spinal cord problem present actually with lower motor neuron signs? And the fact that I'm asking the question should make you realize that yes, the answer is yes. So we just taught that spinal cord lesions are central nervous system. They should have upper motor neuron signs, meaning they should be spastic or increased tone. They should also have brisk reflexes. They shouldn't have any early wasting. And the truth is, yes, that is the classical phenotype of a spinal cord lesion, but they can have lower motor neuron signs as well. So they can have reduced tone, they can have reduced or areflexia, and they can also even have early wasting or even fasciculations. And there are a certain list of reasons why this might happen, and we often see that in real life practice. So then you might ask, okay, but how do we know it's a myelopathy? And that is mainly the sensory examination. The sensory examination demonstrates a clear dermatomal or spinal level. And we know that only a myelopathy should be able to give you that there. So now we know it's a myelopathy. Just to say that the vice versa doesn't work. So a peripheral neuropathy or low motor lesion should not be able to give you upper motor neuron signs. But let's discuss why the myelopathy might have low motor neuron signs. So one of the first things is the concept of spinal shock. So spinal shock implies that early on in the disease process, you've yet to develop those upper motor neuron signs. And some people might differ in terms of the duration that you might allow. We often use between 6 to 8 weeks post symptom onset. You still might have low motor neuron signs. So the patient actually might be flaccid, have reduced tone. So not all myelopathies will have low motor. I'm not saying they have to have low motor neuron signs during this time period. But if you do pick it up and it's a myelopathy, it might be due to the fact that it's just very acute. In the same way, if an acute stroke walks right now into casualty and we rush to go and see the patient with this right hemiparesis that started half an hour ago, we're not going to expect the patient to have brisk reflexes and be very spastic. In the acute setting, they might have low motor neuron signs. So that's the first one. The second one is, we know that at the lesion, the level of the lesion is often low motor neuron signs. So what if there's multiple levels affected? And this is what we often call a longitudinally extensive myelitis. So the inflammation covers multiple segments and causing low motor neuron signs a bit more diffusely. Often we find this in conditions such as neuromyelitis optica, MOG, and some of the viruses as well, or TB can also cause a longitudinally extensive myelitis. On that same note of multiple levels being affected, we can also talk about syringomyelia or a syrinx, often as a post-inflammatory change, more of a structural issue, but again, affecting multiple lesions. Now moving on to one of the other very common ones is that often we're not looking at something just isolated, so there could be something else involved. So we use the term myeloradiculopathy. So radiculopathy meaning that the nerve roots are also affected by the disease process. And they're right there by the spinal cord. So it stands to reason. So for example, a TB myeloradiculitis. So that inflammation from TB often spreads to the roots as well. And that root involvement will give you the lower motor neuron signs. Or you have a large tumor that's also infiltrating all the roots. And lastly, also, we can talk about myeloneuropathy. So who said that you can't have a peripheral neuropathy and a myelopathy at the same time, where the peripheral neuropathy is causing the lower motor neuron signs? This could be part of the same disease process. Maybe it's a severe B12 deficiency that's given you both, or it could be two separate diseases occurring at different times. A very poorly controlled diabetic with a peripheral neuropathy who now has cervical spondylitic disease, or a disc herniation in the lumbar region. So the existing peripheral neuropathy. So you have to look at the patient in context. So just to summarize, there are reasons why a myelopathy or spinal cord problem might have some low motor neuron signs, and you just have to say that this is the causes that it could be. It could be spinal shock. It could be a longitudinally extensive myelitis. It could be something like a syrinx affecting multiple lesions. It could be a myeloradiculopathy with root involvement, or it could even be a myeloneuropathy. And you just make your decision based on the clinical findings. So don't get thrown off. And I've asked on how can they have upper and lower motor neuron signs, and someone said, they could have motor neuron disease because I know that causes both upper and lower motor neuron signs. But remember, in this clinical context, this patient has a dermatomal sensory level. We've established that there's sensory issues already, so that should be excluding motor neuron or anterior horn cell pathology. But if the question was, in the absence of any sensory loss, this patient with a mixture of upper and lower motor neuron signs, what can it be? Then yes, you can add anterior horn cell to that discussion. But for now, with sensory loss, we don't include that. So yeah, don't get thrown off in an exam setting where you are pretty much convinced this was a myelopathy, and then you start doubting your clinical skills and saying, why am I not getting this reflex? Why am I seeing maybe reduced tone? Just trust your instincts, trust your clinical findings, and just justify it.